present Dr. Verenga, it was just to show you that we are not just sitting here for an hour and listen and it goes in and out. We go and practice.
Good afternoon, everyone, and thank you so much for this opportunity. My name is Dr. Baloy. Thank you, Dr. Mwaba, and the team for giving us the opportunity to give you feedback on this wonderful initiative. I represent the hundreds of doctors that are benefiting from this. Thank you so much to Dr. Verenga. The lessons are marvelous. We love them. We now call our Fridays Ultrasound Fridays. We love Fridays. We can't wait for the sessions that we're about to have even now. I just want to demonstrate quickly what we have learned for us. I'll just do a quick biometry. Now I'm about to look for BPD. Yeah, I already found a skull. Dr. Verenga says you don't just measure any round thing, so that's a skull, and I found the false cerebri, and there you can see the tooth thalami. I said we need to look for the tooth thalami, making sure that we are not too low or too high. So I can see a bit of false cerebri here, so I'm going to measure the BPD just across the false cerebri. Measuring from, he said it doesn't matter, we measure from inside out. I saw him measuring from outside to outside, so that's what we do. And then next I will do the head circumference, which I didnn know that it is what we use for gestational age. So I used to use BPD because I thought that's the standard, but thank you so much for that. And then from here I got actually looking for the femur length. Oh, femur length used to be horrible. I used to pray for the femur to come to the probe. Thank you so much. So I'm just trying to make sure that I get a nice horizontal plane and have that swinging motion to bring the image to the center. And I see there we go, almost. And then I'll measure this femur. Actually says we should measure the diaphysis. So moving on, just by moving the probe from the symphysis pubis going up, you can see we started with the head, and then of course there'll be the chest and then the abdomen. So this is the abdomen. You saw there was a fetal heart, so I went a little bit lower below the fetal heart. Then I see the last rib, then I know I'm almost in the right plane. And then I see the liver there, you can see on the left side. And then I see also the vertebra. So I think Dr. Verenga will correct me, I think this is the right plane for us to measure the AC. And as he has already taught us that we're gonna measure from outside to outside. I'm still struggling to get a nice perfect view. He said he saw the adrenal gland. Oh, I can't see the adrenal gland here. I don't know, I think it's maybe this one, but this is where I'm going to measure my AC, because I see the last rib. I think this is the inferior vena cava, this is the liver. So I'm going to measure right in this plane from outside to outside, and being very careful not to compress, because I know I used to put so much pressure on the abdomen, causing the abdomen to be ovoid, so I'm avoiding to do that. All right, thank you so much. I can't wait to hear feedback from you, Dr. Verenga. Thank you so much. I look forward to this session that we're about to have now.
It's super impressive, Doc. I'm blown away with what the guys are doing there. It's amazing. I have no words for this. I'm just impressed, to be honest with you. Guys, well done, and keep it up. Keep it up. I'm totally blown away. Thank you.
She's a true registrar in our department, and we didn't hire any model to do this so that we can impress you. This is exactly what is happening in our practice after you have taught us. And I believe me, it's not only her, there's everyone in our department and everyone in the whole of Limpopo, and the people who are listening, they are trying this skill. So we will try for the next sessions, and we want you to just critique, and so that the other team members can also do the same in their own individual space. And then maybe with other sessions, we can give the doctors from different areas to do the same, like our doctors from Botswana, Namibia, even Zimbabwe. And I must say, among the people from Zimbabwe, they are the ones who are sending me and asking for those videos. So it's very good for everybody.
Yeah.
All right, great stuff. So it's 3 o'clock, everyone. Thank you so much for joining us again. This is another installation of Happy Friday, Happy Verenga's Day, where we sit and get taught by Dr. Verenga, the fetal maternal subspecialist from Zimbabwe. And let me welcome everyone. Thank you for joining us. The doctors from Ghana, Mozambique, Zimbabwe, everyone, including our loyal supporters from Kawazimbi. Dr. Verenga, go ahead.
Thank you so much, Dr. Dakalo. Thank you for the opportunity one more time. So thank you once again for taking time to attend. I'm Dr. Verenga. For those who are attending for the very first time, it is a passion that we cherish to be doing fetal medicine and also to be teaching. And this is the outline of the presentation. Before I get onto it, probably let me again acknowledge the wonderful work which is being done by Dr. Dakalo and his team, the Pelvic Floor Foundation, and also our team here in Zimbabwe, the Fetal Medicine Foundation in Zimbabwe, and of course our biggest inspiration is Professor Kipros Nicolaides, who really supports our practice of fetal medicine in Zimbabwe. So thank you so much, everyone, including the colleagues who help in putting up some of the amazing images that you are going to see today. So this is the outline of the presentation. I'll just take you through a quick pre-test test. Then we'll do a little bit of embryology, not too much. Then I'll show you some of our data so that you can relate probably to your situation. Then I will take you through the examination of the biometry plans. Then we'll look at the common fetal abnormalities. Look at the image on your left, the left of your screen. State what is it that you can identify what the abnormality is likely to be. Just to give you a tip, we're at the level of the head here, probably closer to the BPD, head circumference plane. This is where we are. So just mention what you think is wrong with this baby's head. Then the next image on your right is the image of the baby's abdomen. Again, mention what you think is wrong with this image. This image will be discussed in the presentation, so you are going to mark yourself and see how good you are at recognizing structures. To understand the issue of fetal abnormalities, we need to have some understanding of fetal development. There is what you call the conception period, which is the first week there, and this conception period normally corresponds to 2 weeks after the last normal menstrual period. So in other words, we are saying this is 3 weeks after the last normal menstrual period. This is 3 weeks after the last normal menstrual period. And this is 5 weeks after the last normal menstrual period. The reason why we need to understand these stages is so that when a woman comes to us and tells us that, look, I took something which I think is harmful to the baby, we need to know the period at which it was taken, because the period is the one which determines whether we are going to have a malformation or we are just going to have a functional or minor abnormality. So if it happens that a woman takes something which is not good for the baby between 1 to 2 weeks, that is 3 to 4 weeks after the last normal menstrual period, it's either the woman will go on to have a miscarriage or the pregnancy will go on, and we do not expect the baby to have congenital malformations. This is what you call the all or nothing stage of embryonic development. So if it is within 1 to 2 weeks, either the pregnancy miscarries or it carries on as normal. Then the embryonic development period, which is from the 3rd to the 8th week, in women who are having a 14-day ovulation kind of cycle, we are saying this corresponds to the 5th to the 10th week after the last normal menstrual period. So if a woman takes teratogenic substance that harm the baby at this period, the baby is likely to be harmed and to have abnormalities, fetal abnormalities. In terms of the periods at which the baby is at risk, these are the ones shown here. So we can see that when it comes to the central nervous system, the danger to the central nervous system goes all the way up to around 16 to 20 weeks. The baby will still be vulnerable to teratogenic substances. The heart, we are saying somewhere around 6 weeks, then the upper limbs and all the rest is shown on this diagram here. Then after that, these here sort of light colors here, what it shows that if the baby is exposed, we are more likely to have more functional or minor abnormality. We may not expect a structural abnormality on the baby if the baby is exposed. Why do we have to know this as health workers? Because if a woman comes to you and tell you that, look, I was taking a substance which is not indicated in pregnancy, it is important that we interrogate and find out the exact period that the woman has been taking this medication, because it will affect the level of investigation, the level of scan which should be required for this kind of a woman. If the baby is exposed, of course, the majority of fetal defects may come without any exposure to teratogens, but we are saying if the baby has abnormalities, what are the commonest abnormalities that we may expect? In the central nervous system, these are the kind of defects that may occur due to exposure to teratogenic substances. We may have spina bifida, myelomeningocele, which is an open spina bifida. Then we may have hydrocephalus. We normally call it ventriculomegaly if we do not see an obstructive pattern in the uterus. Then we also have holoprosencephaly. I'll take you through all these conditions in the presentation. On the heart, we may end up with AVSD, arterial ventricular septal defects, or coarctation of the aorta, transposition of great vessels or great arteries, or tetralogy of Fallot. Then on the extremities, we may have amelia. Amelia means either we may have absent or shortening of the limbs. Then adactyly and also meromelia. Then on the eyes, we may have small eyes, microthomia, we may have cataracts, we may have glaucoma. On the face, we may have cleft lip and palate, and we also may have absent kidneys or more cystic kidneys. And on the placenta, we may end up with fetal growth restriction, which we covered last week. Then to just show you this chart from the World Health Organization for 2010, when you look at the cause, the leading cause of why babies die before delivery or after delivery. So when babies die, 10% globally, by the 2010 figures, they were dying because they had some abnormalities of some sort. So 10% of the babies who were dying, they were dying because there was an abnormality on the baby. Then I will show you this data. This data is one of our data, which was done in one of our survey, which was done in 2007. So these were the leading cause in our setup. So what we can learn from this pie chart is that congenital anomalies are nowhere near in the top 5 of the leading causes. It's not because they are not there, it's because we did not have the ability to scan all the pregnant women and diagnose the abnormalities in our setup, so that most of the abnormalities may end up actually being recorded in this unexplained intrauterine fetal demise. So the message is, fetal abnormalities do exist throughout the world, but in some parts of the world, we may not be able to diagnose them because there is no widespread use of ultrasound. If there is widespread use of ultrasound, skills of identifying abnormalities may be limited. So I believe that this training is one way of trying to address this gap, so that our perinatal mortality figures will not reflect hidden mortality like in this situation. Because in obstetric terms, if you don't know why certain things happen, you cannot come up with the intervention to reduce the cause of death in that area where you do not know. So it is important that we know why these 70% of babies are dying. Then to just show you from our work, since we opened fetal medicine unit, we scanned 2,700 pregnancies. Out of the 2,700 pregnancies, we had 79 fetuses with defects. That was an incidence of 3 per 100, which is expected because ours is a quaternary center where all the abnormal cases are referred. Of these 79 fetuses, there were 124 abnormalities. That means other fetuses had multiple abnormalities. So when we look at this data, we see that cardiovascular central nervous system were the most commonest fetal defects, abnormality, followed by central cardiovascular system, then followed by the face and also skeleton and GIT and also the rest. In terms of what was common on cardiac defects, where the AVSD is one of the commonest, and also tetralogy of Fallot were the commonest, and of course the rest is shown there. Then when you go to the central nervous system, where the ventriculomegaly is the most commonest, myelomeningocele as the most commonest, as the second commonest, and followed by holoprosencephaly. They were the most commonest abnormalities. I'll go through these abnormalities for you. Then the renal with the hydronephrosis, and also the rest were almost appearing at the same rate there, from renal agenesis to posterior urethral valve and others. Then the face with cleft lip and palate, also had hypotaylorism and all these other defects, what we identified in our series. Then on the abdominal GIT with gastroschisis, I'll take you through some of these defects. The commonest were fetal ascites, with omphalocele or exomphalos, then of intestinal dilatation and also esophageal atresia, and I think another case which I didn't put there of duodenal atresia, which I will show you one of the image. Then in terms of skeletal dysplasia, skeletal system with melia and also kyphoscoliosis, clubfoot, and also chondroplasias. From what I've just presented to you, it is clear that even in our setup, in African setup, fetal defects do exist and they need to be looked for because they are some of the leading cause of unknown fetal or neonatal deaths. Then how best can we identify babies with congenital abnormalities? The best way to do it would be to do a fetal anomaly survey, that is to offer a fetal anomaly survey to all the pregnancies in our location. What is fetal anomaly survey? It is a systemic examination of the fetal anatomy from head to toe by ultrasound. The most ideal time will be between 18 to 22 weeks. And all pregnant women should be offered a fetal anomaly survey, and we'll be looking for all these defects which I have mentioned before. However, doing a fetal anomaly survey requires extensive training, and this requires a highly skilled personnel which may not be available in most of our settings. But what is it that we can do in our settings if we are able to do basic scanning? So if we are able to do basic scanning, what we need to do is to do what we call a limited survey targeting common defects. This limited anatomy survey is what I'm going to present to you now to say if we are able to do a basic ultrasound scan, we are not highly skilled enough to do a detailed fetal anomaly scan, but we are skilled enough to do a basic ultrasound scan. How best can you help in identifying congenital anomalies? So I'm going to take you through the common plans that are done when you are doing basic obstetric scan and see how best you can use those ones to screen for common defects. So let's look at the head and the brain, right? So when you look at the head and brain, we discuss this plane. This is where we do BPD at circumference. This plane is very important in screening for fetal defects. First of all, whenever you are doing BPD at circumference, you need to be able to identify these structures, because these structures, if they are present, it's highly likely that the major defects which I will show you are absent. First of all, you need to make sure that the skull is present and it's looking normal. Normally, the skull should be ovoid in shape, not circular in shape. It should be ovoid in shape, and there should not be scalloping of the skull bones in the front, which we identify as a lemon head. That should not be present. So the skull should be rounded and should be normally ossified. Then the midline should continue as shown there. This is the interhemispheric fissure. It should continue when you are doing your BPD at circumference. Then you should be able to see these structures, which are the anterior horns of the lateral ventricle. This structure should be visible, and you should also be able to see this box. This box is the cavum septum pellucidum, which we mentioned when you did biometry. We should again be able to see the thalamus. This is the thalamus, this organ which is painted there. That's the thalamus. It should always be present when we are doing BPD at circumference. Then, of course, the third ventricle should be difficult to visualize. Normally, just a slit which you see, the third ventricle, which is normally even difficult to visualize. But the moment you begin to see it, it may mean that there is a problem. There is some dilatation of the ventricular system. Then the midline should continue all the way to the back as well. That's the false cerebri, should continue all the way to the back of the baby's occiput. Then the posterior horn of the lateral ventricle should be visualized, and the choreplexus should be visualized, and it should not have any cysts in it. And when we measure this distance, the width, it should be less than 10 millimeters when we measure the distance. If we are able to get this kind of an image and we assure ourselves that all these structures are there, it's highly unlikely that the baby has major central nervous system defects, some of which I will show you just now. When you are trying to do a head circumference, you may get lost a little bit and go to the back of the baby's skull. You are going to see this structure here. This structure, which is also shown there, this structure is the cerebellum. That's the cerebellum. These are all posterior fossa structures. So that's the cerebellum just at the back. When you are trying to do a circumference, sometimes you get lost and you find yourself seeing this structure, which is the cerebellum. So that's the cerebellum there. And the space behind the cerebellum, we call it the cisterna magna, which should be less than 10 millimeters when measured. But sometimes you just need to eyeball and see if it is increased or not for basic screening. So that's the cisterna magna space there. So that's the cerebellum and the cisterna magna space. So if you are able to see these two images, the one at the level of the BPD circumference and the one at the level of the transcerebellar plane, which I've just shown you, here you have ruled most of the leading malformations of the baby's brain. Then when you come to the stomach, to the abdomen, when you are trying to do abdominal circumference, we normally see the stomach. I'll just show you that when you do these sweeps, you see the stomach and you also see the heart while you are trying to do there. But this is the plane we do the abdominal circumference. We should always see one bubble. Always one bubble there, and the bubble should be visible. It should be visible. If you don't see the bubble, then there is a problem. I'll show you some images where the bubble is there. So that the stomach bubble should always be seen, and also the umbilical vein should always be seen there. That's the umbilical vein, and of course these are the aorta and the inferior vena cava. So that's the plane of the abdominal circumference. We should see one bubble. We should see the umbilical vein. We should not see other bubbles inside the abdomen or fluid inside it. Then that while you are trying to do abdominal circumference, when you move up and down, you are going to see the exact point which has 3 lines where the umbilical cord is going in there. And when you go down the baby, as shown there, you will see the fetal bladder. So that's the fetal bladder there. It should always be visible. If you cannot visualize the fetal bladder, then there is a problem, or the fetal bladder appears too large after scanning for 30 minutes and it doesn't, then there is a problem with the fetal bladder. These images, you don't see them on the common plane, but sometimes you may discover that close to the spine, you are seeing some 2 structures, cystic structures, just on the sides of the spine. These are the renal pelvises, which in this case are more marked, a little bit dilated, minimal hydronephrosis there, because they are more than 6 millimeters. So this is just some minimal hydronephrosis. This is dilated renal pelvis. That is the collecting systems of the kidneys. So that's the bladder there. You will also be able to see while you are scanning the femur, which when you measure should always be within normal range in terms of the central. You should also try to see the extremities. That is the humerus, the radius, and the ulna, and make sure that indeed the hand is there, and also the feet. And we should also try to see that the lower limbs, we have the thighs, you have the legs with the 2 bones of the tibia and the fibula, and also the foot should be seen. That is examination of the extremities. You might not be doing all these planes during the biometry, but the moment you start scanning, try to check for these structures and make sure they are there. I'm going to introduce another plane which we have not talked about throughout this talk. When the baby is lying, giving you its back, that is the back to the back of the mother. If it is put in the back to the back of the mother, when you are sliding the probe on the broad axis, going from the baby's head down to the baby's pelvis, you are going to pass through the baby's thorax, and you are going to see this structure beating the way it is here. So this structure we are looking at is the baby's heart. That's the 4-chamber view of the baby's heart. Anyone who scans should have an idea of the baby's 4-chamber view. I'm going to take you through the 4-chamber view now to say, how do you analyze the 4-chamber view? So for the 4-chamber view, first of all, when we eyeball the heart, we should make sure that the heart is filling probably a third, but less than half of the thorax. It's not enlarged, to make sure that it's not enlarged the heart. And we should make sure that the apex is somehow pointing to the left of the baby's shoulder to make sure that the angle is correct. We desire an angle of between 30 and 70 degrees. We should also make sure that these ventricles are appearing equal. I'll take you what these ventricles are, and the arteries are also appearing equal. And we should make sure that the valves are opening and closing. These are the AV valves. there, and we should check this offset. It may be difficult probably to do at the level of the basic, but you should try to make sure that this valve is inserting closer to the apex than this valve. This is the tricuspid septal valve. This is the mitral septal valve. So you should make sure that this is what we see. To make it very simple, when we eyeball the heart, the four chambers of the heart, the ventricles should appear equal, and at the same way, the atria should appear equal, and the heart should not be seen to be filling the chest and should be seen to be pointing to the left. This is the summary of how you should examine the four-chamber view. So when you look at the four-chamber view, that's the right there, which normally is a moderator bend, right at its end there. That's the moderator bend. It doesn't go all the way to the apex. That's the right ventricle. Then with the left ventricle there, then the right atrium and the left atrium, and of course with the ascending aorta there. So that's the examination of the four-chamber view, which we should try to do when you are scanning to make sure that the four-chamber view is normal. Then that's the lungs. You should always make sure that the lungs are there. There's not fluid in the thorax, and you should again there the other left lung should always be present. Then when you continue to slide towards the baby's neck, when you're at the position of the four-chamber view, you are going to see some three vessels. These are the three vessels you are going to see. I hope this image is clear where you are, but you are going to see that there is this vessel with a valve there and another vessel which is just close, which is being cut transversely. So you can see four-chamber view. You just slide upwards. You see these three vessels. This image is a little bit easier to produce because you are just sliding going to the baby's neck. So that's the pulmonary, and that's the aorta we are cutting transversely, and the superior vena cava. So this vessel should always be there and arranged in this manner or in this order. When we do this, we'll be excluding quite a number of the cardiac defects. If we don't see them in this way, then the baby will need a fetal echocardiography and to be referred to a specialized center or fetal medicine unit. This is difficult. I don't expect it to be easy. The heart is difficult. So if you are finding it difficult, please don't say it's a difficult topic. Then fetal anomaly survey of the face. The profile view is not easy to get a profile view, but sometimes you are going to bump on the baby's profile when you are looking at it. The question is, what is it that you should look for? So if you bump onto the baby's face, you should make sure that the forehead appears normal, is not protruding forward, neither is it flat, and you should make sure that the nasal bone is present, because in certain cases, you may have hypoplastic nasal bone or even totally nasal bone aplasia where there's nothing. Then you should always make sure that the chin is present as well. Again, if you are lucky or if you are persistent, you may see these two black structures. These two black structures are the orbits, and what you see inside are the eye lenses. And when you look at this image, what you want to see is to make sure that you have these two eyeballs, and on top of that, we can fit another orbit in between. If you are satisfied with this, then you can tell yourself that the orbits are present, they appear normal. I've put on these structures. I know they are super difficult to get, but you may see this structure. This is the palate or the alveolar ridge or the roof of the mouth, which we use to screen for cleft palate. And of course, the lips, sometimes you bump onto the lips. It's not an easy scan to get the lips, but you may bump onto the lips. So this is the lip there. These are the nostrils we see and the nose bridge. So we use this to screen for cleft lip and also this cleft palate. I'll show you some images of all these abnormalities. Then the spine. If the baby is showing you the spine, sometimes when you go from side to side, we are going to see the spine the way we are seeing it there. All we want you to check for is to make sure that the skin is covering the spine, is to make sure the skin is covering the spine is shown there, and that the spine is going all the way to the tip, and that there's nothing right at the end there, because sometimes you may have the sacroposterior teratoma right at the end, but you want to make sure that the spine is nicely covered and that you are seeing a railway line like structure, so that the skin there covering the spine should always be seen all the way up to the tip. And of course, you want to see all the way up to the neck, including the sacina magna and this kind of plane. You want to to see this for us to make sure that the spine is indeed normal. Right. So I've taken you through this, what I would call standard planes for basic obstetric ultrasound. So when you are doing this basic, what are the kind of common abnormalities that you are going to bump on? The common are based on our own experience from the fetal medicine, from our own data, which I just showed you there. When you are trying to do abdominal circumference, sometimes you may bump onto these kind of pictures. You will note that there is some fluid, excess fluid, or some dark appearance within the baby's brain. So this which you are looking at, these are distended posterior horns of the lateral ventricle. They are measuring more than 10 millimeters. One of them was 18 millimeters. The other one was 22 millimeters. So this represents the dilatation of the ventricles, and we call this ventriculomegaly. Then we have one of our other case again. This was severe ventriculomegaly, so that this ventricle on its own was 38 millimeters, and you can barely see the brain. So this is severe ventriculomegaly. For this one, there was an obstructive pattern, so we gave it hydrocephalus as a diagnosis. The difference between ventriculomegaly and hydrocephalus is that if we don't see an obstructive pattern to the flow of CSF, we normally label it ventriculomegaly, but if there is an obstructive pattern, we label it as hydrocephalus. The question now is, how do you say this is ventriculomegaly? Because it is the ventricles which are dilated. You are going to distinguish from the other fluid-filled spaces because the midline is maintained in ventriculomegaly. So you can see the midline there. So the midline is maintained in ventriculomegaly. I will show you other conditions where the midline is not there. But in severe ventriculomegaly, which is probably beyond this course, the midline may actually rupture and you may end up with just one ventricle there. Right. So how common is this condition? This condition is very common, more common than what is reported postnatally. In prenatal findings, between 18 to 23 weeks, it's as common as 1 in 100 cases, but at birth it's as common as 2 in 1,000 because some of the babies like this may be miscarried, some are terminated. So they may not be reported in postnatal data, but this is very common if we are scanning according to protocol and also examining the baby's head the way we said we should. Chromosome abnormalities may be associated with this, more so if it is a case of mild to moderate. In severe cases, normally chromosome abnormalities are not that associated. And we want you to know that some of the leading causes can be due to fetal infection, such as toxoplasmosis and cytomegalovirus, and intracerebral hemorrhage may also give us ventriculomegaly. In terms of what we have to do when we see this condition has to be referred to a specialist center or a fetal medicine unit for further evaluation, because in this case, we need to offer the woman diagnostic tests that may include amniocentesis for karyotyping. So that's the management. And in terms of the outcome depends on the etiology, number one. Number two, the outcome also depends on the severity of the condition. Normally, mild cases, the outcome is good. The severe cases, the neurological handicap is very high, so that it may get to 50%. But all this counseling should happen in a fetal medicine unit or a specialized center. The second condition, which is also a leader condition which you may come across, is you are trying to do BPDH circumference, but you are going to miss the midline. There's no midline to see there. You try by all means to scan, and all you are seeing is this fluid-filled space there, and you are wondering what you are looking at. This condition is called holoprosencephaly. What is holoprosencephaly? Holoprosencephaly is a condition where the baby's head has failed to divide between the 3rd to the 8th week. The baby is supposed to divide in the sagittal plane, in the coronal plane, and the transverse plane, but if the baby's head as brain fails to divide, during that period, we end up with a condition called holoprosencephaly, where we just have one ventricle filled with fluid with very little brain tissue in the margin. All of prosencephaly spectra, we have what we call the alobar type, the semilobar, and the lobar type. But the type which we should know, which you should not miss at basic scanning, it is the alobar type, which I am showing you right now, because it is lethal. Holoprosencephaly on its own does come with other associations. It comes with mid-fascial defects. For example, this one of our baby here, we're trying to look at the orbits. You can see that the orbits are very close to each other there, very close, because there's a mid-fascial defects. The midline does not also divide. So we may have hypotaylorism, which means the eyes are too close to each other, or we may have a cyclopia where we have one eye, and this was the baby when the baby was born. So it's a very ugly condition. It's a condition which is scary for the mother, which we are saying should not be diagnosed in 3rd trimester as what is happening in most of our hospitals because of the lack of skills to diagnose this kind of conditions early. So if we look at the BPDH circumference plane according to the protocol which I just presented, we can pick or suspect this condition and refer to a center where a diagnosis can be done early and prevent psychological trauma to most of our mothers. So in terms of other associations, 50% of babies with holoprosencephaly will have Tau syndrome, which is trisomy 13, because it is a lethal condition. A lethal condition, that means you are not going to meet any person with a low holoprosencephaly walking in the street. So what it means is that it's a lethal condition. So this condition should be picked up and the woman should be over termination depending on the situation in the country laws. But the woman should be told that this baby will not be viable if they have a lobe holoprosencephaly. Posterior fossa abnormalities. Posterior fossa abnormalities are a little bit complicated, are a little bit difficult, but I'm going to take you some of the images which you may bump onto while you are trying to look at the BPDH circumference. So you are trying to look at the BPDH circumference, and you see this kind of cystic structure at the back of the baby's brain. This cystic structure is an arachnoid cyst which has now pushed the wall of the brain, and we are now seeing the lateral posterior one of the lateral ventricle displaced to the front. This is an arachnoid cyst which is on one of our patients there, and that's the cyst there which I've colored there. Then sometimes you may see that instead of seeing the cerebellum, we are seeing this fluid-filled space there, which is again a black pulse cyst, which is at the back of the baby's brain, which is part of the anode carrying malformations, which we see there. Then sometimes you may also see that the cerebellum may look small without the evidence of vermis, where we have conditions which we call Rhombencephalocenas Synapses. These are difficult conditions for basic scanning, but we have this kind of disorders. Sometimes we may not see at the back here the cisterna magna. The cisterna magna may be totally obliterated, and we see this in what we call banana-shaped cerebellum, which is also a sign of myelomeningocele or open spina bifida. You are trying to look for this cisterna magna. It is absent in cases of banana-shaped cerebellum where the cisterna magna is obliterated. Right, and the nuchal fold. This is how we measure the nuchal fold. I think I'll skip this because this is a basic scanning training. These images are not ours, but are from the pathology book, Fetal Abnormality book by Professor Palladini. So this is Acronia condition. Acronia and anencephaly are spectra of one condition. If we do scan babies at 11 to 13 weeks plus 6 days like we do, we are going to discover that you see these babies who will have a head there, but the skull seems to be missing and the brain is present. This we call acronia. This is the same condition as anencephaly, but in most of our setup, we see the anencephaly spectra because women do not have early scans, and most of them, they deliver without scans, and all we see is the missing brain. But the reality is that this is one condition which, because of exposure to amniotic fluid, the brain is going to dissolve and we end up without brain because it's being exposed to amniotic fluid. So we end up without brain at all. But if we scan babies at 11 to 14 weeks, we're going to see that there's a brain, but the skull is missing. And for these babies, when we try to do the BPD, head circumference plane, we're going to fail to see the midline. The midline will be missing for these babies. So if you are scanning a baby, you will see when you do the early pregnancy what a midline in early pregnancy looks like. If you miss a midline, you need to refer these babies to a specialized center so that we don't miss acronia. We do not want women to be diagnosed of anencephaly in third trimester because there's no baby, there's no person who is walking with anencephaly in any part of the world. It's a lethal condition. How common is it? In UK, it's reported as 5 per 1,000. In our setup, we do not know, but because most of our women are not taking folic acid, which is known to prevent this condition, we suppose that this condition is fairly common in our geographical region. Sometimes you may see what is called frog face eye sign when you look at this baby trying to see the face. This is normally second and third trimester kind of diagnosis. It's also part of the diagnosing of anencephaly. The management is termination of pregnancy. If it is indeed anencephaly, probably for the sake of counseling, the woman will need to be referred for fetal medicine unit. But this condition is lethal. There's no one who walks around with anencephaly. Open spina bifida. When you are trying to get the image of the spine, as I showed you, sometimes you may see that there's a cystic structure. You don't see the spine going all the way. This was one of our babies. It's actually the same baby here who was delivered. So you see that there's this big cyst which you see at the end of the skull of the spine, and the spine doesn't seem to continue as a railway line. These are the features of an open spina bifida. Spina bifida may occur at various levels. We also have this other baby there. We had it just right at the sacrococcygea area. That's a spina bifida, just where the nerves are just protruding there. We can see that there is a mass and there's non-continuation of the upper part of the vertebral bodies there. So this is open spina bifida. Open spina bifida, the outcome of course depends on the level at which it is the baby is affected. If it is at the thoracic level, the outcome is not good. If it is like this baby may walk but may probably have problem of sensation and so forth. So that is the reason why if you suspect a spina bifida, you need to refer to a fetal medicine unit so that prognostication and also level of affection can be determined. The other signs which you may see, which include lemon head and also a banana-shaped cerebellum, which I mentioned, may be difficult to identify at the level of the basic scanning, but there are other signs that may be shown or that may make us suspect that there is a myelomeningocele on the baby. Chromosome abnormalities may be there in about 8 to 16%, so that is one of the reasons why they have to be referred to a fetal medicine unit to be offered a diagnostic procedure. But it is important to try and look at the spine to see if indeed the spine is making a railway line so that we can identify open spina bifidas. Look at this side. I showed you the 4-chamber view. You can clearly see that there is no nice 4-chamber view to see on this baby. What we are seeing that there is now a very big gap where we were seeing a very nice crux where the valves were coming out on the 4-chamber view. Now they are missing. This condition is fairly common, as you saw from our own case, our own series. So this is AVSD, Arterial Ventricular Septal Defect. You can see there is an opening there. So that's an arterial ventricular septal defect. This condition is probably easy to pick the moment you are able to identify a 4-chamber view nicely. You can easily see that there is a major defect there. This condition, I'm not going to discuss much about it. The heart is a complicated structure to discuss under basic scanning. So you need to refer this to a fetal medicine unit or a specialized center the moment you pick that the heart does not look normal, because there are other structures that have to be checked as well. Then again, when you are trying to examine the heart, you may see this structure. So you are trying to see a 4-chamber view. You see that, look, the whole chest is now filled with the heart here. And we have this very big chamber, which is the atrium, which is now very big. And the valves are thick on this side, which is the right side. This is a condition we call absence anomaly. I've just put it there because I found it quite common in our region here to see this kind of condition. It's also easy to see that the heart looks a little bit bigger and abnormal. This is absence anomaly, where there's an abnormal insertion of the septal leaflet of the tricuspid valve there. So this is another abnormal heart looking. There's cardiomegaly, and the right atrium is undergoing what we call arterialization, and the lost tricuspid valve there. This is the same heart where if you have the ability to do color, you may see that there's a lot of regurgitation, but the color is not part of basic scanning. Just in case there are people who have this ability, should know that you see a lot of regurgitation. We normally cover this under feature echocardiography, so I'll skip this. So duodenal atresia. We are trying to do an abdominal circumference. While you are trying to do it, you are seeing that there are 2 bubbles there. We said you should never see 2 bubbles when you are trying to do abdominal circumference, but suddenly you are seeing 2 bubbles. This was one of our patients with duodenal atresia. So this is duodenal atresia, where you are now seeing 2 bubbles, and these bubbles seem to connect right there. So this is duodenal atresia. It is fairly common in fetal medicine terms, 1 in 5,000, very common. We see a double bubble sign, and there may be polyhydramnios, especially after 24 weeks in about half of the cases. It is associated with trisomy 13 in a third of the in half of the cases, a third of the cases, about 30% of the cases. So this patient will, these cases will need to be referred to a fetal medicine unit to be offered invasive tests to see whether there is indeed trisomy 21 or not, and also to exclude other defects like cardiac, vertebral, and renal defects which may coexist. The management should be in a fetal medicine unit because of what I just mentioned, or in a specialized center where pediatric surgery do exist. So these are the two bubbles which I'm highlighting there. Then while you are trying to do abdominal circumference, you may see that now there appears to be like two abdomens. You are seeing things that look like two abdomens. The reason why we are seeing two abdomens is at the level of the cord insertion, there is now a gap, and the intestines, sometimes including the liver, like one of our baby here, where the liver is now also in this set. This is exomphalos or omphalocele. There is an anterior abdominal wall defect there, so the wall contents have now been pushed because there's a lot of pressure as the baby grows. So the abdominal contents are pushed into this sac, and this is what we call exomphalos. It's a midline sac defect. Very common at 12 weeks, at 13 weeks, because there's a lot of association with trisomy 13 and 18 in about 50% of the cases. Most of the babies die in uterus because for trisomy 13 and 18, Patau and Edwards syndrome, mortality, intrauterine mortality may get to 80%. So at best, the case reported at birth may be way less than the ones you are going to identify that you are scanning, because the majority will miscarry or they will have uterine fetal death because of the association with trisomy 13 and 18. So these defects, when you identify them, again, they'll need to be referred to a fetal medicine unit or a specialized unit to look for associated defects and also to do prognostication, because if the liver is inside, the outcome may be totally different to just intestines inside, and also the association with trisomy 13 and 18. It makes a difference if trisomy 13 or 18 is absent or present. So remember this: if you see two abdomens and what seems to be like a connection, we are probably looking at an exomphalos, and there's a nice covering membrane there. That's exomphalos. It's different from the condition that will follow. You are trying to do an abdominal circumference at that level. When you go to the cord insertion, instead of seeing the three lines, you are seeing some things that look funny inside the amniotic cavity, and these are the intestines that have gone out of the baby's abdomen and they are now hanging in the amniotic fluid. This is gastroschisis. So gastroschisis occurs because there's a defect on the right side of the umbilical cord insertion, and the intestines are pushed out due to the intra-abdominal pressure that occurs when the baby is growing, and they are now inside the amniotic cavity. This is gastroschisis, as shown on one of our babies there. Gastroschisis, because it may be associated with other fetal defects, it is important that the case be referred to a fetal medicine unit or a specialized center so that those defects are excluded. It is rarely associated with chromosome abnormalities like Downs, Edwards, and Patau. So we in our unit don't routinely offer these women an invasive test if this is an isolated finding, if we don't find other defects, and the outcome is relatively good if it is an isolated finding and there is communication with the pediatric surgical team prenatally, so that the baby is prepared prenatally for surgical operation. If the baby delivers outside centers that do pediatric surgery, normally the outcome is not good. This is the reason why you need to identify these cases so that you can refer them, you can do intrauterine transfer of these babies to specialized centers where surgical intervention can be done. To just show you some miscellaneous defects you may bump onto when trying to do abdominal circumference. While you are trying to do abdominal circumference, you may see that there's fluid within the baby's abdomen. This is ascites. There are so many causes of ascites. Again, this will need to be done in a fetal medicine center because there are a lot of tests, a lot of scanning that will need to be done onto this baby before we say the ascites is isolated. But this is ascites we are looking at. Sometimes you will fail to see the stomach. This is one of our baby we had esophageal atresia. We couldn't see the stomach. This is a dilated superior vena cava, inferior vena cava there. The stomach was not visualized. Then sometimes you may see dilated bowels. This is one of our babies with ileojejunar atresia. So these bowels are dilated there. Then sometimes when you are doing the abdomen, you may see that there's another cyst which is now close to the renal to the spine. This is a dilated renal pelvis there, which was 21 millimeters. This is the perfect position to measure. You can see that there is a unilateral dilatation of the renal pelvis. This is hydronephrosis. We divide into mild, moderate, or severe depending on the measurements. Any measurement above 50 millimeters, that's severe. Below 50 millimeters and above 10, that's mild to moderate hydronephrosis. Sometimes you may see a distended bladder with a thickened wall. That's how we come up with the diagnosis of posterior urethral valve. In cases where the kidneys are absent, there may be anhydramnios or oligohydramnios earlier on, in case where the kidneys are present. Just to round up, when you look at the face, if you are good or lucky and you see the profile, sometimes you may see these flat faces. This is a flat face. Again, it's associated with syndromes. These people need to be referred. Or you may see that the nasal bone is very short. This nasal bone was very short there. Or if you are good and you want to look at that image of the lips, you may see a cleft lip. That's a cleft lip of one of our babies. The lips are not continuing there. Or you may see a cleft palate. The palate is not continuing and there's a gap at the level of the palate. When trying to measure the femur, you may see that the femur is abnormally short, or it may even be curved in conditions of what you call skeletal dysplasias. These ladies will need to be referred to a fetal medicine unit because there's a lot of scanning that will need to be done to diagnose the exact type of the skeletal dysplasia. Then, of course, you may see things like choroid plexus cysts, which are not a big problem, but this baby, again, will need a specialized scan to make sure that there are no other associated defects. Thank you so much.
Thank you, Dr. Verenga. As always, Dr. Verenga, this is insightful, and I still reiterate, half of these things you will hear during the ward round, you will maybe rotate as a registrar in ultrasound where they will be doing ultrasound. It just flow above your head, but your experience and how you explain this is so easy and it's so easy to understand. I'm so happy and so thankful to have you, Dr. Verenga. And this includes everyone who's asking questions on the Q&A. So we're going to go straight to the Q&A soon. So let's go straight to it. Let's go to the questions, please. We'll start with Anonymous. Anonymous is saying, Dr. Verenga, after how many miscarriages would you send a woman to high-risk clinic? And from what gestation?
Probably it's not a question related to my presentation, but anyway, I'll answer. Normally we say recurrent miscarriages, at least 3 miscarriages. That's when we are worried to say the woman has had 3 recurrent miscarriages. So those women should be seen in a high risk clinic so that, because they will need investigation as to the reason why they are having miscarriages. The best time to send women with 3 recurrent miscarriages is pre-conception. Before they are even pregnant, they should be sent to the clinic for pre-pregnancy evaluation.
Brilliant. Okay, so I'll just ask all of them, but I've somehow answered in the Q&A. But Charlotte is asking, from what gestational age one can see those features you were showing us in that ultrasound? All these features of the heart and all those features in the brain and all that. What gestation?
Like I said, that anomaly scan is a second trimester examination. It may start as early as 18 weeks to do an anomaly scan, all the way to 22 to 23 weeks for you to be able to see most of the structures. If we try to do it early, the completion rate of the scan will be low because the baby is small. Some machines may not give you enough resolution to see those structures. Again, if you try to do it after 23 weeks, the baby's ribs and other bones are ossified, so you are going to meet a lot of shadows on the images. So you might not see those structures as clearly as you would see them. So between 18 to 23 weeks is the period I would recommend that if probably as a hospital you decide that you want to offer the women under your care an anomaly scan, you should find the most convenient time between 18 and 23 weeks.
Brilliant. So this question we used to get a lot as a registrar, and I used to cram the picture. But you explained it so well today. The gastroschisis, the difference between gastroschisis and infanticide, which one is associated with congenital abnormalities, which has a better outcome. You explained it so well, but just for the sake of our registrars who may still need to go and have an exam, can you just briefly explain again the difference between the two, the gastroschisis and the infanticide?
Thank you so much. So the main difference between the two is that the gastroschisis, the membranes are not covered. The intestines are not covered with a membrane when you look on ultrasound, while in omphalocele they are covered with a membrane. Number two, omphalocele, when we diagnose it prenatally, the association with chromosome abnormalities, like I highlighted, can go as far as 50%. The chromosome abnormality, they are associated with this trisomy 13 and 18, which are very bad in terms of prognosis. Because of that, prenatally diagnosed omphalocele have a way bad outcome compared to prenatally diagnosed isolated gastroschisis. So, however, you may see some postnatal evaluation or postnatal data that may want to compare the two conditions. The reason is most of the babies with omphalocele are going to die intrauterine, so that they are never born. Some of them will die as miscarriages. Some of them probably will be termination of pregnancies. So they may not be counted together with the gastroschisis. They are underreported postnatally because the majority of them die because of the association with trisomy 13 and 18. As I highlighted, that 80%, according to the Fetal Medicine Foundation studies, 80% of babies with trisomy 13 and 18, they die inside the uterus. They are not born. So that is the main difference in terms of the outcome. And in terms of association, because of the trisomy 13 and 18 issue, omphalocele are normally associated with the other major defects compared to gastroschisis. Gastroschisis is more likely to be isolated in terms of abnormality compared to exomphalus.
Lovely. So, Dr. Verenga, this Shatahelo Hatle. This doctor is actually in casualty as he speaks, but he's listening to us and juggling between the emergencies and listening to us. He's saying, how do we access this recording? It is very difficult to concentrate because I'm in casualty dealing with the emergencies. So, Dr. Hatle, thank you so much for taking your time to listen to Dr. Verenga. I think it's a time well invested. If you need the recording, we will send the recording. You can go to YouTube and type Dr. Muaba, and then you can get the recordings. Or you can SMS me your number, and then I can share with you. And then we have Handsome Dube. Mr. Handsome says, thank you so much, Dr. Verenga. Beautiful talk. And La Memulife as well is saying, very informative, Doc. Thank you so much. Another question from Dr. Mapatswa from Mankweng. He's saying, can Dr. Verenga also tell us about the nuchal translucency? When is the right time to measure it? And what's normal? What do we do if it's abnormal? I thought this is a basic ultrasound scan, Dr. Mapatswa, but please go ahead, Dr. Verenga.
Dr. Dakalo, one thing which I can deduce is that I have a lot of registrars in the meeting who are preparing probably for examination. But anyway, I'm going to answer it.
Yes.
I'm going to answer it. I'll do a presentation called the early pregnancy. I think 2 weeks from now, I'll address that. But in nuchal translucency, we do it between 11 plus 0 days to 13 weeks plus 6 days. In terms of whether the nuchal is normal or abnormal, there's a nomogram of nuchal translucency versus CRL. So a nuchal translucency is referred to as abnormal if it is above the 95th centile for the CRL at which it has been measured. I will show, because people have asked, I'm going to put this slide on the early pregnancy presentation.
Oh, beautiful. I think
however, the 99th centile of the nuchal translucency is 3.5 millimeters, above which it is abnormal irrespective of the CRL. That's the 99th centile of the CRL. It's 3.5 millimeters. Above this value, if you get a nuchal translucency of 3.5, irrespective of the CRL length, it is abnormal. In terms of what we do with it, I think it's beyond discourse, but this woman will need diagnostic testing.
Yes, Dr. Verenga, there's still more questions. Let's try to squeeze them with the little time we've got. Nzala Amase, what is the difference between ventriculomegaly and hydrocephalus? You have explained it so well, but maybe do you want to recap quickly for Nzala Amase so that he can understand it?
Good question. I'm saying good question because I've seen most of the reports that are done by most people that they quickly say hydrocephalus whenever they see increased fluid within the baby's ventricles. But hydrocephalus, we are now suggesting that there's an obstructive pattern to the ventricular dilatation. But what we know prenatally is that most of the ventriculomegaly is not due to obstruction. There is no obstructive pattern to most of the ventriculomegalies that we see. The obstructive pattern, we have to look at the whole ventricular system. Normally, if there is an obstructive pattern, the whole ventricular system will investigate to both the lateral ventricles, the third ventricle, and the fourth ventricle. If we think there's an obstruction either at the cerebral aqueduct or at the foramen of Monroe or Sylvia, any of those places, then we will label that as a hydrocephalus. If you are certain that there is an obstructive pattern, there are features of obstructive pattern that you normally see on scan. One, I think I saw you 2 images of ventriculomegaly. One of them, there was totally, the whole brain was almost destroyed. There was no brain there. And 2, you will see an ever expanding fetal brain, a fetal head circumference. And if it is a blockage lower than all the ventricles affected, will be grossly dilated. These are how we distinguish. If we are not sure that there's an obstructive pattern, it is ventriculomegaly until proven otherwise. Because the most commonest condition is not hydrocephalus, it is just ventriculomegaly, which is the dilatation of the ventricles. And the causes, I think I mentioned them during the presentation.
Lovely. Then from Puti Humutso, she said, thanks for the wonderful teaching. You do help people, more especially in my maiden province. I believe maybe she's referring to Limpopo. We really can't wait for Fridays from now on. You know, we are enjoying these lectures. Stay blessed. This is from Puti Humutso Rachabedi. And then we have Nombasa Mayoko. Thank you, Dr. Verenga. I would like to ask, how does one see a lemon or banana sign in the Spina Bifida?
Right. So a lemon or a banana sign, right. I think, first of all, let me apologize that I didn't put those images, because it's always very difficult to draw a line between giving a basic course and an advanced course. So I always try to fear that, look, a man not saying too much that I should be saying for a basic course. So I'm sorry for not putting it, but let me just illustrate on this head. I think you can see my screen there. Let me just illustrate. Let me go to where the head is. So for a banana sign, what we normally see on a banana sign is the scalloping of the baby's head. In terms of the banana sign, we will see the scalloping like this. So this is the lemon sign. Due to the traction that will be happening at the level of the spine will show this kind of scalloping. So the spine will be shaped like this. So there will be forward scalloping. This is the lemon sign. The lemon we are referring to is a lemon which we call it the European lemon, because most of the lemons we get in Africa are actually well rounded. But the lemon kind of, the European kind of lemons is almost like this. So that's a lemon sign. So when you come to the banana sign, so the cerebellum will now be pulled at the back and occupy the sacina magna space. So it will appear like a banana, like this. So that's a banana-shaped cerebellum. So it will obliterate this hypoechoic space, this anechoic space you are looking at, and it will occupy because there is traction that is happening to the tethered spine at the back. Because the spine is now tethered, so as the baby grows and lengthens, the back part of the brain is pulled back into the foramen magna. So the cerebellum will end up filling the sacina magna space. So that's a banana sign. Thank you.
Marvelous. I think we're running out of time. Can I just squeeze the last, if you can allow me, Dr. Verenga, let me squeeze the last comment or question from Dr. Mapule Mahasha. Thank you so much, Dr. Mwaba and the team, for this ultrasound training program, as well as the Wednesday lectures. They are extremely insightful. Thank you for sharing knowledge so beautifully. Yeah, on that note, next week, Wednesday, we are going to Malamulele Hospital. We're going to have our Wednesday presentation live from Malamulele. So for the doctors who can reach Malamulele, you are welcome, more than welcome to come and join us. We're going to present acute collapse in pregnancy by the anesthetist, so it will be very fun. So you are more than welcome to come there, and we will be presenting from there. Dr. Verenga, your sessions, my friend, I mean, they are just so popular. Like this side is like a fat cook, you know, when you have, I don't know if in Zimbabwe you have fat cooks, but this side fat cooks. You see, people still stay after we pass the 4 o'clock time and by 16 minutes because they can't get enough of what you're giving us. Thank you so much. Dr. Verenga, your last word, please.
Thank you so much for taking time to listen. One of the reasons why you should identify fetal abnormalities is so that women can be given reproductive choices. There is no woman who deserves to carry a lethal defect to term because the system has missed it. It should be out of choice, out of an informed choice. So please go out there and look for holoprosencephalus, for anencephalitis, for gastroschisis, for omphalocele, for ventriculomegalies, and spina bifidas. Thank you so much. Bye-bye.
Thank you so much. Goodbye. Everyone, thank you so much for joining us. Bye-bye. See you next week, Wednesday, Kamalamulelo Hospital. Bye-bye.